So a surgeon I used to really respect told me, he was like, Don, I don't know why you're wasting your big brain on psychiatry. He was like, a monkey can do psychiatry. And I was like, what do you mean? That's insulting. That's my profession of choice. And then he was like, well, a monkey can do surgery too. And I was like, what does that mean? And he's like, when you do the same thing over and over and over again, and you finally understand the concepts, like it's not difficult anymore. It's just like a repetition. And if you show a monkey how to do the same thing over and over again, eventually it'll figure it out. And I was like, is he calling me a monkey? But I think the same thing's true for the body of knowledge that we're trying to learn in psychiatry. Is like, I think from the perspective of the student, when you're trying to learn it and you're still working and they're not giving you very clear directions all the time, it's like sitting at the foot of the mountain and you're looking up at the top like, how the heck am I going to remember all of this? Okay. So I want to talk about some principles that help you scale the mountain more efficiently. All right. So when it comes to medication prescribing and switching, titrating, cross-tapering, and tapering are three concepts that you definitely have to master, because there are consequences to how you do it. Okay. So for example, you're starting a new patient on any medication, and you give them too high of a dose too soon, well, what's likely to happen? What do you think is likely to happen?
They have side effects.
Side effects, exactly. So, if you give too much of something too fast too soon, you're more likely to have side effects, right? And then also the flip side of that, sometimes if you go too slow, it's hard to assess the impact of the medicine, right? So before we kind of dig into it, let's kind of define the words. So, in my mind, titrate refers to starting someone on the medicine and pushing them towards therapeutic dose. And the therapeutic dose may be the max dose, or it may be just the dose that works for that patient. Okay, so that's the titration.
And I feel like that one's more straightforward because even the prescriber guides, they tell you
right.
the steps.
They kind of give you.
They give it to you.
Exactly.
Not with tapering.
And there's some nuances to that. So we'll kind of focus on some of the nuances of titrating, because you're right, your Hippocrates or whatever drug database that you have can help with that. Okay. But there are some principles to that. The second is tapering. So tapering is the process of taking a patient from the current dose they're on to safely a lower dose or off of it. Okay. And then cross-tapering will be, this is how you it's one technique to transition a patient from one medication to the other without being completely off meds. So you're starting one and increasing the dose and stopping another one, but there's a period of time where you're on both medicines. Okay. And that's very common in mental health because a lot of our patients don't do well off meds. So there's a lot, you don't want to like wash them out. So wash out when you take them completely off of everything or completely off the medicine and then start the new medicine. So there are situations that you want to do that, but most of the time you end up cross-tapering medicines. Okay. Of course, there's exceptions. So let's talk about the titration first. So titration, the purpose of it is to start someone on the medicine and safely get them up to a therapeutic dose. Okay. In a timely fashion so that you don't have consequences of the disease process itself. All right. So you're right. It's a little bit more simple because a lot of times the databases will tell you start at this dose, in 2 weeks increase by this much, and et cetera, et cetera. All right. The few things I feel like it doesn't tell you though is for specific populations, there's some wiggle room in that. Here's an example. So it might say start fluoxetine. You're going to start at 20 milligrams or 10 milligrams. It'd probably say 20 in the thing. I'm not sure, right? Then it might say increase by 20 milligrams every X amount of weeks or whatever, right? So that approach might be a generic approach, but I'm thinking about the experience that the patient has with medications. So if I got somebody completely naive to medications, they've never taken an antidepressant before, I'm probably not going to start them on 20. I'm going to start them on half of a starting dose. Even if the recommended dose is 20, I might put them on 10 because I don't know exactly how you're going to respond to the medicine. And there's no harm in starting lower, but there's definitely harm when you start too high for that person, because you really don't have an idea of how that person's metabolism works. So some people are going to be rapid metabolizers, and some people are going to be what we consider normal metabolizers, and some people are going to be slow metabolizers. And unless you do a genetic test, you're probably not going to know. And more than likely, in most places, you're not going to genetic test every single person that comes through, right? Unless it's just kind of part of your protocol that you have at that particular clinic. So oftentimes, if someone's naive or they have a history of being really sensitive to medications, I'm going to start them at a lower than recommended dose, because here's a key point. The objective of titrating a medicine, the first objective is safety. I want to make sure it's not making things worse first. And then secondly, I want efficacy after that. And I tell the patient that, hey, I want to start you at this dose. The reason I want to start you at this dose is because I don't want to hurt you. I want to get comfortable. When you take a medicine, you shouldn't feel like you're walking around drugged. You should feel like it's not causing any additional burden. All you're starting to see is benefit. That's my goal for you. And then I set realistic expectations. However, there are some side effects to the medications. So remember, part of titrating is educating. So the patient's not going to push themselves up to the max dose or follow your directions if they're not aware of what can happen and they're prepared for the potential side effects that the medication can have. So the better educating you do about the medicine, the more adherence you'll get, and the better opportunity you have to push them through the dose range. But also, the better opportunity the patient's going to have to recognize something when something goes wrong so they can stop it or follow your directions or contact you or whatever to transition or pivot off of that medicine. So education is key for a good titration, in my opinion. All right. Now, the flip side of that is someone they've already done like 80 medicines. All right. They have a lot of experience. Their brain's been exposed to all these antidepressants and antipsychotics and benzos and stuff like that. You have to assume that the body is used to an exogenous source of chemicals coming. So in those situations, I can be a little bit more assertive if I want to be. So, for example, if I'm getting somebody and they were on 225 of Effexor and they were on this happens, and they were on, 80 of Prozac, and you're like, oh my God, I'm surprised you don't have serotonin syndrome, right? Then I want to switch them. I'm not going to say, all right, well, let's start Lexapro 5 milligrams. Like, their brain's going to be like, F is this, right? See what I'm saying? Right, so that particular patient, you may be a little bit more assertive with the medications because you know they've had a lot of medication burden in the past and they may be able to tolerate a faster titration. Now, another thing you look at is the acuity of the patient and the setting that you're doing it in and your ability to follow up the patient. So if I got someone who's really sick and they're really, really depressed, I'm probably not going to give them Lexapro 5 and say, come back and see me in a month. All right, I'm probably going to direct our to start on Lexapro 5. In 3 days, I want you to go to 10. A few more days after that, go ahead and take it to 15 and see me back in 2 weeks. See what I'm saying? Like, I'm going to be more assertive with the dosing. I'm going to see him more frequently. Right? Versus someone who's not as acute, I might say, all right, let's just start with 5, do that for 2 weeks, and then go to 10. I'll see you in a month. Right? So acuity plays a role. Their experience with medication plays a role. And really the only two choices are, I'm going to be conservative or I'm going to be aggressive or I'm going to be somewhere in the middle. Does that make sense? All right. So the less acute, the more naive, the slower I'm probably going to go. The more acute and the more experienced with medications, the more opportunity I have to be more aggressive with the medicine. And the other thing is the setting. So if you're an outpatient, most of the time you're going to see patients at the highest frequency once a week, but that's rare. You don't have time to do that because your schedule's full. You might get lucky and you can do it twice a week and see them in 2 weeks, but in a lot of really busy clinics, you might not be able to see them back for 3 to 4 weeks. So outpatient, you might not have the opportunity to be as aggressive based on your ability to follow them up. So if you know you can't see anybody for a month, don't be super aggressive with their dosing in that month because you can't follow them up. Because what they're going to do is going to create unnecessary phone calls. And it's going to make you work more because you're seeing your patient and you get more calls because you're too aggressive with your medicines, and you get poor adherence because you're too aggressive. Versus say IOP. It's built that I'm seeing them every week, and other therapists are seeing that patient every day. So I can be a little bit more aggressive because I'm going to see you once a week. Versus inpatient, I can be even more aggressive because I'm going to see you every day. See what I'm saying? So it's about the ability to supervise will also dictate the pace of the titration. the last little thing I would say is just like experience with the medication. So as you start prescribing, you'll notice how people are responding to the medications. And you'll notice that some medicines, if I do it too fast, most of my patients do terrible. So I'll do it slow. Versus other medicines where you know that you can be really aggressive with throughout the bat without much consequence. And that just comes with time to kind of get a feel for that. All right. But if you follow those first principles, you'll be safe on most titrations. All right, let's talk about a taper. Now the taper gets a little more tricky, but actually it doesn't. It really kind of falls into really one main principle. Okay. It's steady state. And we kind of talked about that. In fact, let me rewind a little bit. Because some medicines on your titration, you need to check blood levels. Say like lithium or Depakote or something like that, all right? And you gotta check blood levels. Well, how the heck do you know when to check the labs? You can look it up for each individual medicine, and you can memorize that over time, or you can understand the concept of steady state. That's the pharmacokinetic stuff you were talking about, pharmacokinetics. Remember that medicines typically reach steady state in 4 to 5 half-lives of the medicine. So the simple way to do it is like, look at the medicine, look at the half-life. Let's say the half-life is 24 hours. I know that you're going to be at steady state in 5 days. So if I started a medicine that needed a lab, I know I can check a lab order in about 5 days because they'll be at steady state and to be accurate at what they have in their bloodstream. Right? And you always want to do a trough as well. Okay. What are you going to say?
Well, what is steady state? Like, what does that mean?
Good.
Like,
okay. Great question. So steady state. So if you think about like when you take a medicine, your body is looking at that thing as a foreign object. Like these chemicals are not supposed to be here. So it's going to do what it's trained to do. Your liver is going to break down the product. Your kidneys are going to try to excrete it. Right? And its goal is to get it to the blood level of 0 because it's not supposed to be there. Right? So what's going to happen when you take your first dose of the pill? Your blood is going to spike, and then your body's going to be actively trying to get it out of your system. So you're going to have a nadir in the blood level or a valley in the blood level, and it's going to keep going down. So if you don't take another pill, it'll go to 0. But what tends to happen is you take another pill the next day, and your blood level starts going back up, and then it goes back up to another peak. And then your body's like, oh, hell no. And so I'm bringing it down, right? And then it's going to happen again. So the steady state is this phenomenon where the peaks aren't as high and the valleys aren't as low. So when you reach steady state, in the beginning it's going to be like peak, valley, and then eventually it's going to be like you're not going to get as high of a peak in the medicine. And then when you're off the medicines and your body's kind of breaking it down, it's not going to go down to a blood level of 0. You're going to be in a window, and it's going to do like this. That's steady state. Does that make sense? Mm-hmm. All right. So the reason for that is if I have a therapeutic dose that I need to have you at, I want to keep you in that window so I can get the effect of the medicine. So for example, lithium. We know like therapeutic values of lithium is between 0.6 and 1.2. Okay. Now to get to that, well, I got to give you a certain dose of the lithium to get you into that window. And I promise you, if you take a lithium pill and I take your blood level an hour after, you're probably outside that window. You're too high. And you got to peak. All right. And if I wait, half-life of lithium is about 24, 36 hours, I guess. I can't remember. If I check your blood level and I don't give you another pill in about 3 days, your blood level is going to be about 0. Okay. But I'm going to keep giving you pills every day. And eventually, it'll steady out in that window. It'll be a steady state. Okay. And then what you do is when you check the blood level, you're going to check it, like say for example, you take your pill every morning at 6 a.m., you're going to tell them to skip that 6 a.m. dose and come get their blood labs in that morning. And what you're going to see is the bottom of the steady state trough, right? That's an accurate time you want to check it. You don't want to be like, all right, take your pills that morning, and then they come in, and then their lithium's like 3.1, and you're like freaking out. Oh God, they're gonna have lithium toxicity. No, you just took the blood level right after they took their pill. All right. So you want to. So the reason that's important is I know that it's 4 to 5 half-lives to steady state. Another reason that might be important is some medicines won't show their side effects until they get to steady state. For example, Vraylar. Vraylar may have some late occurring side effects because the half-life is super long. So it might be several weeks before it gets fully to steady state. So you may have people they may tolerate the first 3 or 4 weeks, and then week 5 and 6 they start having side effects because it's just not getting steady state. So that's possible. So just being aware of the half-life of medicine can be helpful, and you educate your patients. Hey, you may do well the first few weeks, but you may notice some side effects emerging after about a month or so. So let's check in 4 to 6 weeks, okay? Versus something that has a half-life of 5 days, you don't really have to tell them that. They're gonna have the side effects by the time you see them again in 2 to 4 weeks. See what I'm saying? So the flip side of that happens on the taper. So when you're doing a taper, your assumption is, based on the half-life, that's how long it's going to take for it to get out as well. So something with a short half-life, the blood levels are going to plummet pretty fast, and your brain's going to be like, what the crap, man? What happened? I'm used to this exogenous serotonin, all of a sudden it's not there. And as you know, the body strives to be in homeostasis. So you can have upregulation of receptors and downregulation of these receptors and da 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 da. So if a medicine has a short half-life, the blood level is going to plummet pretty quickly, and your body does not have time to make the adaptations for that not being there. Does that make sense? So here's an example. Something like Prozac has an 80-hour half-life. So I'm assuming it takes 4 to 5 days, 4 to 5 half-lives for the blood levels to get way down. So that's 80 times 5, that's 400 hours. That means I don't have to taper that medicine at all. I can just stop at cold turkey and it's going to self-taper because the half-life is super long, right? Versus something like Paxil that has a very short half-life, it's like 12 to 24 hours, I think. So anything like that, within 4 to 5 days, their blood level is going to be way low. So your brain just went from having exogenous serotonin to like, boom, straight down. So the patient had withdrawal symptoms, okay? So a quick pearl is, if you're trying to decide if I need to taper this or not, you look at the half-life. A short half-life in my mind is, less than 3 or 4 days. To make it safe, less than a week. If it's less than a week, it's probably, intermediate or short half-life. Here's another clue. If it has an XR form, it's a short half-life. So if it says venlafaxine extended release, that implies venlafaxine has a short half-life. Paxil, CR, or control release, that implies it has a short half-life. You don't see a Prozac extended release because it already has a long half-life. See what I'm saying? So that's a clue that something may have a short half-life if it has a XR, control release, XL form. So Wellbutrin has an XL form, et cetera, et cetera. So that's your clue, but you always just look it up. So even if it has an XL form, I'm still going to slow the taper down, because usually when you make it an XR form, it don't make it that much longer. It don't make it like 6 months. It just makes it like, if it's 12 hours, it might make it, 48 hours. It might make it 72 hours. See what I'm saying? So it's still relatively short half-life most of the time. So when we're done with this lecture, you should go on and pick some of the medicine, look at the half-lives, and then decide for yourself, should I self-taper this one? I mean, they can just stop it, or should I taper it? Just to get used to looking at the medicines to see which ones you might taper and not taper. Okay. So
none of the stimulants they taper, I noticed. They just take them off.
But that's because there's really no withdrawal to it. You know what I'm saying? So some medicine you have withdrawal, some medicines you don't. Okay. Antidepressants definitely have withdrawal. Antipsychotics definitely have withdrawal. You can have withdrawal akathisia. You can have like dystonic movements and stuff like that if you have withdrawal from antipsychotics. So you got to consider a taper for those. Some mood stabilizers, you may want to consider a taper for those. Stimulants, however, there's really no withdrawal symptom to it. Benzos, benzodiazepine can cause almost like an alcohol withdrawal. So they have to be tapered. All right. So that's a good point that you brought up, is that it depends on the properties of the medication, how it affects the body and the brain. So if things have known withdrawal symptoms, you have to be careful to look at whether you need to taper or not. So there's not a whole lot of different classes in psychiatry that you won't consider tapering. It really is just the stimulus, now I can think about it. So if we look at our classes, antidepressants, yes. Antipsychotics, probably yes. Mood stabilizers, most of them, yes. Psychostimulants, not necessarily. Now, some patients will complain about it, but most don't. Yeah, most classes of medicines, you got to consider a taper other than stimulus. There may be exceptions because I'm thinking of on top of the head, but as far as I can think of, those are the ones. All right, so let me kind of boil that down to the simplest concepts. When you are tapering a medicine, the half-life is super important, and the class of medicine is important. So just remember, always try to just remember the exceptions. So you have to remember a whole bunch of stuff. So just remember that usually stimulus you don't have to taper. Everything else in psychiatry you should consider a taper. When you decide whether to taper or not, you look at the half-life. If it's short, to me that's like 24, 72 hours, maybe like, if it's like less than a week, I would probably taper it, okay? The shorter the half-life, the slower the taper. So something like Cymbalta is notoriously bad for withdrawal symptoms from antidepressants. So you want to slow that taper down as much as you can. So here's an example, and here's another trick you can do to slow a taper down if you don't have the right doses available. So Cymbalta comes in increments of 30. So it's like 30, 60, 90, 120, right? If I got a patient on, say, I don't know, I'm making up something, he's on 60. And then I drop him down to 30, and by a day and a half, 2 days later, he starts having withdrawal symptoms. Well, since it's a capsule, there's no intermediate dose between 60 and 30. So one strategy I may do is alternate dosing. So I may do 60 day 1, 30 day 2, 60 day 3, 30 day 4, 60 day 5, 30 day 6. That's from a blood level standpoint, that's creating an intermediate dose. And then once they can tolerate that every other day dosing, I might do, depends on how sensitive they are, I might do 60, 30, 30, 60, 30, 30, then 30s. Now you made it successfully to 30. Usually just alternate day dosing is enough. Okay. I've had patients that literally it was so bad they had to open the capsule, port the beads, count the beads, or either weigh them and be like, all right, I'm just going to cut it by 10 beads. That's how impactful it can be to too quickly take people off certain medicines. Okay. So keep in mind that's a strategy that you can do if you can't quite make a dose, because there's a lot of pills out of capsules and you can't break the capsules. Okay. Always pay attention to it in your thing if you have the opportunity to open the capsule or not. And some things you shouldn't break the tab. All right, last thing I say is, like, I don't have it memorized for every class, because I mostly do depression. So this is my quick thing. There's only a few that I just know that I just self-taper. Trintellix, self-taper. Vraylar, which is antipsychotic but also adjunct antidepressant, self-tapers. Prozac or Fluoxetine, self-tapers. There's a couple more. Most of the other ones, you may have to taper them in some direction. So remember, the shorter half-life, the slower you go with the taper. Okay. Now let's talk about cross-tapers. So cross-taper, you're kind of combining those two principles. Typically, my goal during a cross-taper is just to prevent a crash. I don't want to have withdrawal symptoms. I don't want them precipitously have worsening symptoms. Right? So usually my objective is to get people, I want to get people in a situation where they got antidepressants on board the whole time, and I can safely get them off their original medication. So I'm not expecting to get to the max dose of the new medicine while they're still on the other medicine. So it's usually like something like, I may start tapering the other medicine first, and I'm trying to maybe get you down to 75 or 50% of your old dose. Then I'm going to introduce the new medicine. Okay, so say let's use Cymbalta again. Let's say you're on Cymbalta and you're on 120. I might walk you down to 90 or 60, and then I may start the new medicine at a low dose, because I just don't want your serotonin to completely crash. So let's say if I'm switching to, I don't know, Lexapro, I might Here's an example. It doesn't always have to be this way. 120. I'll say, all right, I want you to reduce your Cymbalta down to 90 milligrams. We're going to do that for a week. Get to 90. They successfully do a week. Okay. All right. Starting week 2. Okay. I want you to introduce 5 milligrams of Lexapro.
Why a week?
Well, just based on that's kind of arbitrary. It might be longer than that because I picked Cymbalta in my example. Because remember, Cymbalta has that short half-life and harder to get off. Some patients can do it, some patients can't. So I would say maybe a week to 10 days. I might even do 2 weeks, depending on if it's Paxil or Cymbalta. So let's be realistic. It's Cymbalta. All right, we're gonna do 2 weeks at 90. Then at the end of 2 weeks, I want you to introduce 5 milligrams of Lexapro, starting really low. All right. Once you start the 5, then you can take it down to the 60s. Okay. We'll successfully do that, maybe another 10 days, then go 10. Then we're gonna go down to 30. And then I might just keep them at 10, or I might take them to 15, and then we'll taper off the Cymbalta the rest of the way. But Lexapro only got 2 doses, really 10 and 20, so I might get them all the way to 20, and they'll be coming out the Cymbalta simultaneously. So it doesn't have to be exactly the right amount of days. Like, I'm not gonna look at the half-life and be like, all right, the half-life is, 48 hours. That means I need to change the dose every 1 week. You know what I'm saying? Like, it's kind of patient specific. So the shorter the half-life, the less frequent I'll make the changes. So it's like really, really short, I might like make a change by every 10 days to 2 weeks. If it's kind of intermediate, I might do it once a week. If it's really long, but not quite Prozac long, I might make a change, every 4 days, 4 or 5 days or something like that. So something the patient easily remember, just every 5 days, I want you to go down by 10 milligrams or something like that. Because I know the half-life's a little bit longer. Okay? So saying all that means it's not an exact science. You're still reading how the patient is responding to the taper or the titration, but you have some principles in mind. Principle is short half-life, slow taper. Long half-life, faster taper or no taper needed at all. That's the principle. Okay. With a cross taper, I just don't want you to be off of all the medicines. So I'm going to apply the 2 principles. Something with a really long half-life, I'm just going to stop you off of it. Like say Prozac. That's why a lot of new patients I'm treating for depression that haven't been on there, I'm going to start with fluoxetine or Prozac. Mostly because of that long half-life. I'm going to try it, and if you hate it, no worries. We just stop it, go to the next thing. All right? But I'm keeping in the back of the mind, there's Prozac still in the system, so I'm going to do my taper or my titration for the next medicine maybe slightly slower, because I know the Prozac's still coming out of their system. Or I might choose Lexapro as my first drug. I do that because that one only has 2 dose ranges. It's 10 and 20. So I know between now and the next time I see you, I can probably max out that medicine pretty quickly if you've already had experience with antidepressants. But if you're naive, I might take my time getting over that 20. But it doesn't have a short half-life. It's kind of have an intermediate half-life. It's not that hard to come off of. See what I'm saying? I never, ever start anybody that's naive on Cymbalta or Paxil or medicine like it when it comes to antidepressants. Now, with antipsychotics, it's a little different. Like, what you're treating tends to be different. It tends to be more acute, like if you're manic or you're psychotic. Like, I'm thinking a little bit less about the half-lives. I just want to stabilize you. So I'm not like, oh, I don't want to start Risperdal because of withdrawal symptoms. I'm not thinking like that. I'm like, oh, you need some help. Let me give you the Risperdal. And a lot of those patients that are on antipsychotics routinely jump to different antipsychotics. So if I'm taking you off a Risperdal or something like that, and I'm looking at, I don't even know the half-life Risperdal off the top of the head, I'm looking at it like, this is a kind of relatively shorter half-life. It don't matter because I'm going to throw you right back on an antipsychotic anyway. So a lot of cross-tapering happening in the antipsychotic kind of realm. It is rare that you're just going to take people all the way off antipsychotics if they need an antipsychotic. Because if you have bipolar and you have a manic episode all the time, you're probably going to stay on an antipsychotic. So you probably won't have a situation where you're tapering people all the way off. It's rare. Okay. So, all right. I think those are some of the kind of tenets to think about. So understanding steady state, understanding half-lives and why that's important to let you know how fast or how slow you need to do something. Understanding that different classes of medicines may or may not have withdrawal symptoms associated with them, but honestly in psychiatry most of them do in some capacity except for the stimulants. Okay. Understanding that it's not exact science, but you have some principles to kind of guide what you're doing, but what makes the most impact is your patient and how they're responding to it. And then a lot of our patients have a lot of experience with these meds, and usually they can tell you. They can be like, last time I came off with so-and-so, I thought I was going to die. So okay, take my time tapering people off these medicines. Even if it's something that you wouldn't expect them to have a reaction to, I'd be more cautious with them because they told me, they took this similar thing and had a lot of withdrawal. I'd rather be cautious. Okay, so hopefully those tips are helpful for understanding that concept.